All right, welcome. Good afternoon. And we're going to get started on this session. So welcome to Special Topics in Geriatrics. This is the series on healthcare reform. It's the second session that we've put on, and this is going to be about primary care and healthcare reform. We're really excited for this one because this is also going to be as a webinar, so hopefully we could be able to access and reach more people if they can't make it here today. We've been advertising like mad how to connect to this webinar with a URL, and all it needs is a PC and their internet connection. This is sponsored by the East Texas Geriatric Education Center Consortium, funded by HRSA, and I'd like to acknowledge our partnership with the East Texas AHEC, who have been really valuable in helping us connect to our service area. Can everybody hear me okay? All right, very good. All right. This is our agenda. This is going to be a 2-hour session. We have one speaker that I'll introduce in a second, Dr. Victor Serapina. He'll have to leave possibly a little at around 1:30, 1:15 or so to get to clinic, and he's saying, yes, I have to go to clinic. So I'm going to be real quick here. And then we're going to have a little video and a little debriefing session afterwards, and we can have some discussion, so we'll have some time to do that. There's also evaluation forms, a lot of paperwork in the back that you can take care of. Next month is, in April, we're not doing March because of spring break. In March, we're having an interprofessional panel looking at standards of primary care for older adults. As I said, this is a series of 4 sessions. The last session will be in May, which will also be a webinar looking at future implications of healthcare reform. Okay. For CME, we are offering 2 credit hours for MDs, DOs, nurse practitioners, and physician assistants. There's paperwork in the back for evaluation forms and credit requests, as well as an evaluation form, as well as a sign-in sheet. I need to disclose that Dr. Serapina has no relevant commercial, financial interests, or affiliations to disclose. Okay. We are offering about 2 hours, we'll round it off to 2 hours, of C&E credits for nurses. LVNs will provide them with a letter of attendance if needed, if they request it. Again, there's a separate credit request and evaluation form for the C&E, and also a separate sign-in sheet to get your C&E credits for those that qualify. The planning committee members, the faculty, the content specialists of this C&E activity have disclosed no relevant professional, personal, or financial relationships related to the planning or implementation of this C&E activity. Okay. We also have CE credits for physical therapists that will be pending. We have an online group that we work with to get them. Occupational therapists can also get credit by sending in their evaluation forms, and we'll send them a letter of attendance for their CEUs. There are forms for those as a webinar. If you would like to get your CE credits, if you're viewing this from your computers, we can send you the paperwork, all the forms that you'll need for obtaining your CE credits. And there's a good way to contact is just to get with me. My name is Tony Danuzzo, and I direct the GEC. Okay. And also, we have a lot of areas up in East Texas, different locations there that this is also being broadcast through our AHEC partners and collaborators. Okay, so we're okay so far. All right, great. I don't want to take a lot of time here because I know Dr. Serapina's time is really limited for today, and I want to make sure he has enough time to do everything that he needs to do. His presentation is towards a rational, integrative healthcare system. His bio is there, but what I really want to say is that we had our first session, a wonderful overview by Laura Herma on healthcare reform, and a very inspiring talk by Dr. Brody, Howard Brody, about the ethics of healthcare reform, and some discussion there. I believe that this is a wonderful follow-up to that, because the first line of defense for healthcare is primary care. And Dr. Serapina is one of the best that I know in explaining and talking about the benefits and issues related to primary care and the impact of the healthcare reform. So without further ado, I think we'll bring up Dr. Serapina.
But as a practicing physician, primary care physician, having been a rural physician for a number of years, worked in suburban areas as well as here at UTMB, I think I've noticed what most of you have is the wheels have fallen off the truck of healthcare. We really have a broken system. Throwing money at a broken system is like trying to put a lot more money into an old clunker of a vehicle that really needs to be replaced. And so I'm going to really talk about kind of alternative models of healthcare as opposed to alternative payment systems. Payment systems are part of the issue, but primarily this is what you read about in the newspaper. It's really not about healthcare reform, it's about healthcare system payment reform and who's going to get what and how things are paid for. Now, to some extent, that drives services, but it's kind of looking at the thing backwards. So my primary tenet really is that the foundation of any improved system of care, of any payment reform, of any rational return to principles of social justice within our healthcare system and the care of the public's health is absolutely going to require that we make primary care central to the planning of healthcare and healthcare policy. What we need is patient engagement. We need ongoing and caring relationships with patients, optimal management of chronic disease, as well as improved efforts in wellness and prevention. Now, what we have instead, despite impressive technical advances in medical care, is a current healthcare system that is fragmented. Care is typically reactive and episodic, and we really don't have close relationships between patients and providers. There's a verse in the book of Proverbs that says, where there is no vision, the people perish. So a couple of years ago, the Institute of Medicine had a symposium called Integrative Healthcare and Public Health. And it looked at integrative medicine across a spectrum of specialties from businesses and academia to practice and what its role in the healthcare reform debate was going to be. This was just at the time that Obama's administration had really started having Senate hearings and so forth. So this was held in Washington, and it was highly attended. Actually, it was the largest attendance at any IOM symposium that had been there. I was invited to give an 8-minute presentation, my hour of power. In 8 minutes, I was asked to describe what I thought a physician or a healthcare provider of the future would look like. And since we were talking about integrative medicine, and I'm going to give you some definitions and distinctions between integrative and integrated, which are two different things in my view, I came up with this schema. Okay, so here's the physician of the future, right? Some of them are in this room. So I broke this into two different categories, columns, process and structure. Okay, so the process that we need in any advanced healthcare system is patient-centeredness, okay? Not doctor-centeredness, not team-centeredness, not hospital-centered, office-centered, but really about patient-centeredness. And part of the structure of any of us in healthcare is really to be navigators to help patients kind of pass through this system and make it an optimal situation for them. For example, I had a patient last week. He was a retired A&M professor. He was recently diagnosed with CML, chronic myelogenous leukemia, and renal carcinoma. And he came in the office basically in tears because the prescription for Gleevec, which the oncologist told him he would need to be on, was over $5,000 a month. his annual income was only about $20,000 a month. And he was really in tears about this and depressed and upset and ready to sign up for hospice. And fortunately, I talked to our social worker. I also talked to Dr. Markowitz, who's head of oncology, and we hooked him up with the, I think it's Pfizer that makes Gleevec. They have a patient assistance program, and we were able to get this medication provided for him. So that was an example of, I wasn't going to cure either of his cancers. That's kind of out of my specialty, but I helped him navigate the system. And now he needs some counseling for his depression and stress, and we're working with that. So that's one example of how we can really be patient-centered and not be doing something that is, you know, prescribing a drug or doing something else. Traditionally, medicine particularly has been very physician-centric. The doctor is kind of central to the process of care, but increasingly this is becoming ineffective and inefficient. And so what we have to do is look at more team-based processes, working, and I'm going to talk about the patient-centered medical home as an example of that. Outreach-oriented, looking out from beyond our clinics and our hospitals into community centers, into churches and social organizations and schools, places where healthcare is provided where people are and where they live, and making it more accessible, more affordable, more available. And by definition, this is going to be multidisciplinary. It's not going to be just the doctors or just the nurses. We're going to have teams of physical therapists and dietitians and other healthcare professionals, health coaches that help us in this process. What we have found with high-tech medicine is we've lost some of the kind of laying on of hands aspect, the art of caring. And it turns out that American people want both. Many surveys have said, you know, I don't really just want high-touch medicine. I really want to have all of the buzzers, the whistles, the scans, anything that I can. But I really want to have that caring, high-touch relationship as well. Part of that can be conscious design of the healing environment. If you walk into an average clinic, it doesn't really evoke a lot of kind of calmness and relaxation. You know, it's busy, the seats are kind of commercialized, maybe there's a fish tank bubbling over here and a couple of plants, but there's not really a sense of trying to make it an inviting space for people, where the placebo response is actually activated when you come in. If someone is stressed out about their cancer or their other condition, they walk into a kind of a commercial-grade clinical environment, it really doesn't activate their own healing process if they don't feel comfortable there. So we need to do a better job at this. And this costs money, but there are hospitals, integrative centers, wellness centers, spa-type facilities around the country that recognize that this is an important aspect of starting the healing process and giving the message to the patient that we care. And I know Dr. Brody has written a lot about placebo, and placebo is not a non-effect. I mean, it is a significant part of the healing process and everything we can do to support that, including our built environment, but also the attitudes that our staff and other members have. Certainly something that came up a lot at the IOM and you're reading a lot about is kind of this whole process of genomic individualization. Some people really think there's going to be a lot of spin off genetic engineering and so forth, but the fact is we haven't really found any cures with genetic engineering. What we have found, though, is that we can make effects on patients' genetic expression through epigenetic variations. The epigenetic means you've given a certain book of life, your genome is your code book, but it is expressed according, in many cases, to factors related to lifestyle and diet and stress. And all of those factors can alter your risk for diabetes, for cancer, for other things, even though those are in your family tree. That being said, there are predictors increasingly available to say, okay, this person has a family history of, say, this cancer or this diabetes. What are the other kind of genetic markers we might be looking for to know how high risk that is? So this is very, very much personalized and predictive medicine at the highest level. And this is really evolving. We're going to see more and more of this. This is what I call a systems biology approach. When people think about primary care, often we say, well, you know, they take care of kind of fairly straightforward stuff, colds and flus and normal deliveries and blood pressure. But the fact is, we in primary care have really become systems thinkers. We have to become systems thinkers because of the complexity of problems that we face. The patient doesn't just come to me with a kidney problem or a heart problem or a endocrine problem or a rheumatological problem. They come with all of those, and they are in some ways related to each other. And this requires really a higher level of thinking and complexity in this systems biology concept, or what I call a functional medicine matrix, as part of what we do. So rather than thinking of primary care as the kind of the easiest specialty, it's actually becoming known as one of the most difficult. So we talk about these prospective, preventive, behavioral, science-based change methods. Ralph Snyderman, who's the former chancellor at Duke, was the head of our planning committee for this conference. And he talked about this kind of longevity of the chronic disease model. And so if this is kind of age 0 and age 80, and this is kind of where disease kind of comes and peaks, what we need to do is intersect and intervene at an earlier and earlier stage, perhaps using some of these genomic and other predictive aspects, lifestyle changes, early before the disease occurs. This is the old Chinese physician was told to be a fine physician if he treated the disease before it occurred. But if he treated it after it occurred, it's a little bit like starting to dig a well when you're thirsty, or making a sword when the battle's already started. So this idea of intervening earlier requires prospective, preventive, behavioral science-based change methods and identification of people at risk. And then this, of course, needs to be studied, and looking at outcomes and the evidence that this makes a difference. It's of very little use to screen for a disease that we don't have any treatment for example. But for diseases that we do have treatments for and we can intervene, the earlier the better. One of the things that I think was left out of my training in medicine, and has kind of come back to us through the integrative, holistic side of medicine, is the idea that the body has a tremendous power of homeostasis, or self-healing. We tend to think of ourselves, or at least the way I was trained, kind of the doctor as a mechanic, so to speak. You know, the body is broken, we got to fix it, we do this and do that, and cut and paste and whatever. But the fact is, much of what we do and can do, and this goes back to that placebo response, is really empowering the patient to normalize their behaviors to help sustain their own self-healing process and homeostasis, rather than seeing only healing as a process that is something that's administered to them. I was talking to Dr. Andrew Weil once. We were at some kind of a meeting, and I said, we were going back to the hotel in a car, and I said, you know, that was one of the major factors I think that he has brought to this discussion in contemporary medicine, is reminding us of how important self-healing and homeostasis is, and how the body's capacity needs to be activated. That's our primary, working with the terrain of the person, that's our primary intervention. And you can easily think about this. Just a condition like pneumonia, we think penicillin or some other antibiotic cures pneumonia. Actually, no. You know, the penicillin reduces the bacterial load so the body's own immune system can overcome it. The same with conditions like HIV. Okay? When you see the inability of the body to recover because of homeostatic insufficiencies or immune insufficiencies, rather than not necessarily only the virus or only the bacteria. So empowering patients is very, it's kind of a sticky wicket in a sense, because patients will come in with some unusual things that they've researched, and they don't really often have the full perspective of the condition. They'll find something on an internet site, and I generally will encourage this. I really want my patients to be informed about their condition, and I want them to be aware of what I'm going to do and all of those things. But that sometimes gets a little bit out of hand, and your role as a healthcare provider is someone with a lot of experience, a lot of perspective, and say, you know, that may read that way, but it's actually, in your case, this is what's happening. And I'm sure all of you who've been medical nursing students have kind of suffered through over-identifying with all the diseases you've read about during your training. You say, I've got that. This is the disease of the week. I got lupus this week, and I've got cardiomyopathy the next week. And my gosh, it looks like it's herpes zoster, you know, or something. So one of the things that one of my patients said this morning to our student, I had a couple students on our integrative medicine elective out at Stewart Road, and what she said is the reason she comes to see me is I don't start with the strongest and most potent therapy first. I said, that's right. If I shoot my biggest gun at the first thing, then I'm out of shots if it doesn't work. So I always, going back to this kind of self-healing homeostasis piece, try natural treatments, nutritional, botanicals, lifestyle, mind-body, complementary therapies, and that is a useful strategy. And the structure of that may be that you've got patients that are in a community context. You have a patient advocate that helps work with you. This concept of health coaching I just breezed over, but this was widely discussed in the IOM meeting. What's a health coach? Well, we don't even know, but the fact is, if Dr. Brody comes to see me 1 month from now for a physical, and I say, well, these are some things that I want you to change and come back and see me in 3 to 6 months, nothing really happens between us often in that 3 to 6 month period. But the role of an evolving physician, which doesn't necessarily have to even be a nurse or a dietitian, although it could be, but someone who is a health coach that helps that person with motivation, with setting goals, with behavioral change, and kind of stays in interaction with them in that intervening 2 or 3 months. And that could be done in a group setting as well. So that's where, I mean, some of the structure of this kind of one-on-one dynamic with physicians doesn't always work to make behavioral change, and other things are necessary. So the process is integrative. It uses this whole nest of processes. And then there's also this kind of meeting here where the physician of the future does get involved in conversations about the environment, about social issues, and policy change and self-care strategies, these things that are so important to the health care of our people and the world. So I was asked to give a definition of integrative medicine in deference to our other healthcare professionals here. I just said integrative healthcare. And this is one that, this is an area I've worked in for many years. I was recently chair of a group of 47 academic health centers, all of which have active programs in integrative medicine. And this was a definition that we came at after many years of crafting and wordsmithing. So it's the practice of medicine or nursing or physical therapy or other health care that affirms the importance of the relationship between the practitioner and the patient, focuses on the whole person, is informed by evidence, and make use of all appropriate therapeutic approaches, healthcare professionals, and disciplines to achieve optimal health and healing. So this isn't simply a focus on disease treatment, it's a focus on wellness, and you notice that it embraces multiple health professions, multiple therapeutic approaches. Maybe they're conventional or standard of care, or they could be complementary. So integrated care, let me just back up a second. Integrated care, and you'll hear that term, and when we were at the IOM, the two terms kind of went back and forth and seemed to some degree interchangeable, but they're really not. Integrative care is somewhat different, and it emphasizes like care coordination across multiple levels, disciplines, organizations, and healthcare teams. And that's a slightly different concept. But integrative medicine is this concept, and it's not limited to primary care by any means. There's integrative oncologists and rheumatologists and cardiologists and women's health specialists, but primary care is where we feel like it expresses its best values. So the topic was rational. okay, rational healthcare system. So how do we balance this kind of biology and technology sides? What do we do to bring the two together, the yin and the yang, the right and the left brain? Well, I'm going to share from several streams of thoughts and documents that I've reviewed prior to this course, or prior to this lecture and over the last several years. And these include concepts like the medical home, facts about the benefits of primary care, and some of the challenges facing the healthcare system regarding this foundational aspect of our healthcare. I'll cite some interesting data from a congressional advisory committee called the Council on Graduate Medical Education. They just released a report in December that I'm going to cite some issues from. It was called Advancing Primary Care, and you could go to the website and download that. Dr. Andy Weil wrote a book on healthcare systems called Why Our Health Matters, and I'm going to just cite a few of his kind of myth-busting comments on that. I'm going to summarize a few of the comments, from the IOM's Integrative Summit and some other sources, and along with that will be some recommendations, some of which you might take kindly to and some possibly not. So let's start with what's going on in primary care. First of all, my tenet is a better balance of primary care providers and specialty providers would go a long way in helping solve issues of access, health disparities, quality, and cost of care in the United States. Countries with universal coverage, such as Europe, the United Kingdom, and Canada, they all have a ratio of primary care providers to specialists of around 2 or 3 to 1. So there's 3 primary care docs for each specialist. In the United States, as I'll show you, this ratio was reversed with concomitant increases in healthcare costs. Dr. Brody shared with me a couple of years ago a report from the Dartmouth Institute, which studies healthcare policy and usage, and it was a shocking finding. You probably read about some of it in the paper because there were some docs down in McAllen, Texas that were billing quite extensively for their cardiac services that were about 10 times as much as surrounding counties. But anyways, this white paper found that the cost of Medicare spending per beneficiary was highest in the area where there were the most specialty care providers. Costs were up to 2.5 times higher than similar areas with the same levels of acuity and kinds of patient care or patient conditions, but with less of the specialty providers. And here's the more shocking part and disappointing: the quality of care, as measured by actual patient outcomes, was actually worse in these areas with a high density of specialists. Why? Adverse reactions, unnecessary surgery, excessive testing, all ran up the tab without improving the quality of care, the safety of care. And it really turns out that just more specialty providers just quite simply resulted in more services being provided. So this is what we call supply-sensitive care. If there's a X specialist in your area, you're likely to use him. And if there's a bunch of them, they kind of vie for each other with, for patients. So this results in unwarranted variation in medical practice and supply-sensitive care. Now, lest you think that I am opposed to specialty care, far from it. As a family doc, the first thing I teach my residents and students is I need to know what I don't know. And we depend heavily on our specialists in our practice. And the appropriate use of our specialists is an essential part of this kind of quarterbacking, team-leading approach to how to field efficient use of healthcare systems. And so we do need, in the evolving years, not only more primary care docs, but as the baby boomers age, we're going to need more geriatricians, cardiologists, urologists, oncologists. I mean, all of these folks are, and people in various internal medicine specialties as well. But it's the balance right now is out of whack. So here's some data. Patients with an identified primary care doctor have substantial decreases in healthcare utilization and improved healthcare outcomes. And this is summarized from multiple studies. Patients with identified primary care providers generate less emergency room costs, have shorter hospital stays. And there was a study from the VA with newly diagnosed lung cancer patients. They found that these patients, same stage lung cancer, if they had a visit and identified a primary care provider within 6 months of their diagnosis of cancer, that they lived 13 months longer on average. Why? Well, the primary care doctor is not primarily responsible for treating the lung cancer. That's surgery, radiation, chemotherapy, whatever. But the fact is they lived longer because the primary care doc was taking care of their other comorbidities, their heart disease, their diabetes, their COPD, their arthritis, other things that could affect their longevity, and significantly did so. So if you have cancer, go to an oncologist by all means, but stay with your family doctor, your internist, because they will take care of the rest of the person. This is the study I just cited from the Dartmouth Institute. And this is what I'm going to talk about a little bit next. A medical home will become a site for continuity, quality of care, prevention, outcomes improvement, research, and improved patient satisfaction. But right now, this is where we're at. Okay, we have a highly weighted specialty care to primary care imbalance. It's about 32% of physicians in the United States are in the primary care zone, and that is dropping, and the rest are in the specialty areas. And we'll talk about some of the reasons why that's dropping, and that's an important part of this conversation in terms of reforming the whole picture. So we feel that if we're going to ever balance the high costs of medical care, from there we have to come back to a better balance here. And the COGME group has made some specific recommendations. Now, although this says family medicine at the bottom, it could be internal medicine, it could be pediatrics, it could be primary obstetrics and gynecology. But this is a very widely discussed topic now among family medicine circles. The primary medical family home has building blocks that involve the patient experience as patient-centered, outcome measures. The organization is aligned with incentives for wellness and health promotion and continuity of care and comprehensive care. And there's meaningful use of health information technology, like we have our MyChart program and other ways of communicating with patients. The primary care, patient-centered primary care home or medical home, patients are found again to have less utilization of services, hospitalization, and unnecessary surgery. Well-organized systems of care, group practices, and integrated hospital systems such as Mayo, Kaiser Permanente, Geisinger Clinic, Intermountain Healthcare have programs like this, and they've had a way of figuring out how to manage their care while reducing costs and improving patient satisfaction. So this is something you're going to hear a lot about, and it's helping to reform the way that family medicine is practiced from the 2 or 3 doctor shop to really that team focus that we've been talking about. And we're starting some of those initiatives now in our family practice program. Well, if all the medical students of all the medical schools in the United States went into primary care, for the next 10 years, we would still actually be short primary care providers. So people have said to me for years, they go, oh, you know, your whole specialty will be taken over by nurse practitioners and PAs. And I say, God bless them, we need their help. Bring them on, okay? Because we need all the help we can get. And the fact is, the role of mid-level practitioners, particularly in rural areas like I was practicing, where there maybe wasn't enough business for a full-time doc, was very helpful. There's been many studies with high quality of care, patient satisfaction, substantial cost reduction. I was asking Dr. Rounds how many nurse practitioners trained stay in primary care, and she said really most of them. However, PAs, it turns out, according to this census report, have reduced their involvement in primary care practices, and they go more into specialty practices, orthopedics and so forth. So that's not going to really help the program as much as if they stayed in primary care. But this is a wonderful opportunity to work as a team and to extend the services to a larger number of patients by training more mid-level practitioners. I'm very 100% supportive of it. Oops. There's our pins, the nurse practitioner, physician assistant pins. I love Google Image. You get all kinds of cool stuff. All right, so let's talk a little bit about the kind of differentiation here between health payment reform versus health care reform. What I'm trying to talk about today is upstream. What can we change upstream so that downstream costs, which is what the health care payment reform is all about, so what's happening downstream after the condition has happened, what can we do upstream to alter that when that patient arrives? It's like the body shop at the bottom of the cliff, and somebody needs to put a guardrail instead of just paying for all those body shop repairs down at the bottom. Okay. Well, there are some concerns. Okay. First of all is the issue of this workforce, and I'll show you some data on that, but who's going to take care of all these tens of millions of new patients under the Patient Affordability Access Act if it comes into play? I think it will eventually. I'm not just sure how or when, but so that's one issue. The support for primary care in terms of education, loan repayment, and reimbursement is key to this, and I'll give you some data on that as well. Another issue is lack of emphasis on prevention, health promotion, and changing lifestyles. This is hard work. Many times patients just don't want to engage in this, but we know that's a single biggest factor in reduction of the rate and risk of chronic disease. Something in the range of 20% of our health outcomes is determined genetically, and about another 70% is our lifestyle, and that's that epigenetic part that I was talking about. So even though the healthcare reform bill talks a bit about prevention and health promotion, there's really not a lot in there. The First Lady is starting to do some work on this in terms of getting kids moving, and I commend that. That's part of where we need to be, is out in the schools, out in the community, and making some cultural change. I'm also a little concerned about kind of the shell game about they're going to save so many billions of dollars from Medicare savings from fraud, and I'm going, okay, Medicare's been around for 40 years. You're telling me you've allowed billions of dollars of fraud just to go on for 40 years. And who did that? And who's going to reinforce it now? Now, there are some bad actors. Now, they think they arrested a guy and his wife in chemo that had bilked Medicare for many years, and somebody else in Florida was doing some fake psychotherapy. So there's some money there, but it certainly is not going to be, in my view, the amount that is predicted. So, okay, let's talk about what happens if you put all these people who are currently uninsured or underinsured into the system. The Council on Graduate Medical Education feels that instead of 32%, we should shoot for at least 40% of primary care to specialty care providers. So today, we've got about 272,000 PCPs covering about 260 million people, all right? So if we were to just raise, this is 32%, raise that to 40%, we need an extra 63,000 providers if we're going to cover the 46 million uninsured. Now, if we even wanted to cover 35% of those uninsured, it would be another 84,000 doctors. And if we wanted to cover 122,000 we don't cover everybody, 122,000 primary care docs would be needed. It's not that many in the pipeline. That's a lot. That's why I say we need other models of care, and we need the mid-level practitioners, and we need other ways of managing this. And insurance companies aren't necessarily the answer right now. Just so you know, your insurance company says you can't get sick again until October 14th of 2014, okay? It's met as deductible for the decade. So get well card from your health insurance company, postage due, okay? Now, I think that there is tremendous value in social rectitude to universal coverage. I think it levels health disparities. There's certainly a social justice issue, this reduction of downstream costs of untreated disease for the children and young adults, reducing expensive ER visits for common problems. When I worked in the emergency room in Colorado, I would have families on Medicaid. They would come in at 2 in the morning with 2 or 3 kids with runny noses, basically. And they didn't want to wait around in the clinic during the day, so they came to the emergency room, and the cost of that visit was probably 10 times what it would have been coming to the office in the day. Prevention would be available for all. I find over the years I have scratched my head and torn my hair out by its roots, that's why I look like this, with Medicare's rules on prevention. You know, if I do a physical on someone and I don't find anything wrong, they won't pay for it. So I got to come up with a diagnosis, okay? This is disease-oriented care. So someone just says, I really want to kind of tune up and have some preventive visit. So this universal coverage would help hopefully level that situation. That's obviously a driver for many social, community, and cultural solutions, patients that are disabled, patients that have limited access to care, people have inability to work because of medical problems. Often it's because they're not getting adequate coverage for not only just medical visits, but nursing visits, physical therapy, medications. And obviously this is a context for measurement of quality of care. It's hard to really claim that we have quality of care when we don't have that kind of coverage. Now this guy got some snake eyes. I know it's weird, but it's all my insurance would cover. Okay, you see his snake eyes. So ICD-9, you need snake eyes. Okay, all right. Okay, so let's agree that upstream changes can and will lower our downstream costs. So here's a couple of documents I'll just touch on as we proceed. This is the Integrative Medicine and the Health of the Public Summit that I participated in 2009. And this is a book that Andy Weil, who's well known in the integrative medicine circles, published last year, very thoughtful on healthcare systems. So the challenges I see, health reform or payment reform, chronic disease management, prevention, workforce issues, and demonstration of effectiveness of whatever system we put into place, whether that's integrative medicine, the patient-centered medical home, or whatever. And we also have the voters, okay? If you've been reading the newspaper with the recent budget reform, little has been paid attention to the major entitlements like Medicare, Medicaid, and Social Security, which are the major expenses in the government right now, and people want to reduce costs, but they go, I want no part of Obama's socialized medicine, but he'd better keep his hands off my Medicare too. So the government's in a situation right now where they can't really reduce the cost of their deficit without making some adjustment to the amount they pay out for Medicare, Medicaid, and Social Security. I don't claim to have the solution to that, but it's really one of the dynamic tensions in our political dialogue these days. So we have toxic trends such as a deterioration of medical practice and philosophy, the need for more low-tech, high-touch medicine. We're failing to provide health care for all. There's a growing influence of money. And this is something, again, Dr. Brody, I keep citing him. He's one of my favorite authors, though. But he's dealt with this over the years, the conflicts of interest and the various impact of pharmaceutical companies and such on the practice of medicine and how it has raised the cost of it so much. And we have to make it more affordable. In fact, you know, if you really want to get good coverage, just go to jail, you know. Well, unless I screw it up with time off for good behavior, I'm in for 10 years of free health care, okay? So, and UTMB's been really footing the bill for a lot of Texas prisoners now, and we provide good care for them, but we're starting to lose money on that. But it is interesting to me that the working poor often have less quality of care than our felons. So here are some themes that, and I'm just going to summarize those. They are available if you want on that website, but from the IOM Summit that I think are important in this kind of overall vision of how a healthcare system could be reformed. So one is just the concept as a vision of optimal health. That is alignment of individuals and their health care for optimal health and healing across a full lifespan. We really don't have a healthcare system right now, we have a disease care system. So the concept of optimal health, wellness, and well-being are really really an essential shift in how we look at our services. Conceptually inclusive means there's a seamless engagement of the full range of health factors: psychosocial, economic, preventive, and therapeutic. We don't kind of split person off. They've got these psychological problems, and we send them to the social worker for their economic issues and send them someplace else for their therapy. But we really need to kind of think of all of that as a single package of services. The lifespan horizon. As a family doc, we say we take care of patients that from womb to tomb, but this health care needs to be, as we talked about, personalized, predictive, participatory, and preventive. Okay? All of those are part of the genomic evolution, and it's part of what we have to do with behavioral change as well. Person-centered, it's just integrated around and within each person, and then prevention-oriented, that is disease minimization as a foundation for what we do. Some other themes: team-based. The care process is a team activity. It's not a solo sport anymore, with the patient as a central team member. When I was in medical school, I worked at a holistic health center, and one of the most, outside of Chicago, and one of the most radical things they did is when they had a new patient, they would have them meet with the team individually. They'd see the doctor, they'd see the nurse, they'd see the clinical pastoral counselor. These were holistic centers, actually were in churches. And then they would have a health planning conference and sit around the table, and who was at the planning conference was all three of the professionals, but also the patient. Radical idea. We're going to talk to you about what we think might be good for your health, but that patient might need to have some input into that. So the idea of this team-based program, but really having the patient centered, where you can assess their readiness for change, the kinds of options that are acceptable to them, is really important. Care integration means integration of care across caregivers and institutions, utilizing advanced electronic methods and electronic communication methods and health records. It drives me nuts when I have a patient move here from Houston and they just had a CAT scan last month for a follow-up for some problem, and they can't find the records and we can't get them. And so what do? We get another CAT scan, you know, and it costs the system a couple of $1,000 for something that was easily available. This is unsustainable financially, and it's unethical. And talk about the radiation dosages, and there's a whole lot of things that come apart with that. Caring integration, which is, I think the patient is, it is the idea that it's person-centered, but it's also relationship-centered. You will see patients that really just do better if they trust somebody. And this is where primary care has an opportunity to really reach out and shine, because we see patients for many years. I've been here at UTMB now for 15 years, and some of my patients have been with me for that long period of time. And it takes some people a long time to warm up to you and to get a sense about what they need, and for you to really understand their whole psychosocial domain. And of course, integration of science. I keep flipping off. Integration of science, that is all the domains from genes to society. We go the full spectrum from the molecular biology to the social dimensions and global dimensions, really environmental issues. All of that, all of the range of science needs to be applied in a really integrated healthcare system of the future. Integration of approaches. This means using allopathic, traditional, alternative, complementary therapies as informed by evidence, and including outcomes-based research. If I refer someone for, say, chiropractic or massage or something like that, I may not ever hear from their provider. I don't know what happened. Otherwise, unless the patient comes back and tells me, wouldn't it be better if we worked together more closely? And of course, then there's policy opportunities. Let's define value in terms that emphasize outcomes, elevate patient insights, account for family and social factors, encourage team care, provide supportive follow-up, and contribute to the learning process. There are lots of policy opportunities in this space. Now, Andy, in his book, Why Our Health Matters, says, you know, part of the problem with our healthcare system is we're living under some myths, okay? And those myths, here's one. Because America has the most expensive healthcare system in the world, it must have the best. We spend a lot of money, it must be a good thing. However, in fact, it does not equate with quality of care, access, or outcomes. In fact, we rate on a scale of healthcare outcomes as about number 37, just about where Serbia is. I don't even know where Serbia is. It's out there somewhere in East Europe, and it's not a place you'd expect to have better healthcare outcomes than the U.S. Here's another myth. Our medical technology is our greatest asset. In fact, technology is very useful, but it's often misused and overprescribed. It's not only overly expensive, but frequently leads to worse healthcare outcomes. I had a patient in the office today. She was enraged that she was addicted to Nexium. Nexium is an antacid. You know, it's not like psychoactive thing, but she could not get off her Nexium without having reflux symptoms. And it's very expensive, and she felt like she was put on it without knowing that she could never come off of it. Well, in fact, I'm trying to get her off of it, but there was a study last year in gastroenterology where they stratified 40 patients into a study. 20 went into a placebo arm and 20 went into a proton pump inhibitor arm getting a drug like Nexium. And none of these patients had reflux disease before they started this trial. But after the trial was over, they stopped the Nexium, and the patients that were in the active arm, they got reflux. They all developed it, okay? And it was like the GI people say, here's our mainstay for GERD and esophagitis and chronic gastritis, and what we're doing is we're actually creating more dyspepsia and long-term conditions, not to mention malabsorption of B12, folate, iron, calcium, vitamin D, and bacterial overgrowth syndrome, other things that are possible with that. So that's an example of a overused technology. Now here we are in terms of healthcare expenditures per capita. Look at the United States. We're way over here, $6,700 a year, and this is the Organization for Economic Cooperation and Development. Average around the world is $2,800. So we're more than twice. Luxembourg comes a little bit close. I think it's because they don't have that many people. But here's, you know, this is kind of the modal place. And if you look at places like Australia, the UK, Canada, that have a nationalized healthcare system, they're half of what we're spending. France, okay, Italy. And their outcomes are improved. Our premiums obviously are going up. We all know that. If you look at the right-handed slide, look at the percentage of increase in premiums for employers and their employees. And then, by the way, are our wages going up that much? Is inflation getting lower? No, staying the same. So we're just really getting to be where this is a major threat to our gross domestic product. Here's another myth. Our medical schools and research facilities excel at creating the finest physicians and most productive medical investigators. Well, I'm a physician, so I'd like to believe this, right? Otherwise, I want my money back from my tuition. But the fact is, we're not, as organizations, delivering what the public needs. The specialty mix is just one of the issues. What the public really expects and why they fund medical schools is to improve the health of the public. And we omit, just as an example, this large areas of education and research on how to help people live healthier lifestyles, which we know is so essential, but we kind of bypass that. We go right for the technological cures. And in a sense, many of our researchers are very reductionistic in terms of their studies, strong emphasis on pharmaceutical drugs rather than some of these non-pharmacological measures that we can use. So these are just some suggestions that Andy put together. How about an Institute of Health and Healing instead of the National Institutes of Health, which again is not really quite correctly named, or the Centers for Disease Control, a focus that gives comparable funding to what is it that helps people become healthier and how do people heal, rather than simply disease-oriented research. What is the placebo response? What activates healing in one person and not another? What are the components of well-being, and how does that differ among populations and cultures and belief systems? And that would take this emphasizing training and cultural change and behavioral and lifestyle change. I think we do this fairly well in family medicine, but I think where it breaks down is kind of that model I was using of where we see the patient here, and then 3 months later, and we haven't done much in between to interact with them and really help them make behavioral change. If you think it's easy to make behavioral change, take a diabetic person comes in and say, okay, you need to lose 20 pounds, I want you to quit smoking, start exercising, change your diet, and do some stress management, maybe take a yoga class or something like that. Well, just if you've ever tried to make a New Year's resolution, trying to change just one thing is hard. But we typically give these people a recipe plan to do all this, and we don't give them any support in between times. We don't assess their readiness to change, what they're willing to do, what the cultural barriers are, and that's where maybe some team approach, including health coaching, may be useful. And we need to incentivize health promotion in clinical settings as well, school, work, community. We've made a lot of impact on this with just reducing smoking in public places and in the workplace. I can't believe Galveston changed their rule about that. It just drove me nuts. It was so happy to see them outlaw smoking in public places. And the literature is actually very good. And that was in Pueblo, Colorado. They reduced the heart attack rate visits to emergency rooms by over 40% in 6 months after a smoking ban in public places. And the vast majority of those people that were having heart attacks were in non-smokers. Okay, so it's a non-smoker getting passive smoke was stimulating clots and so forth, and so that's one. Drives me nuts. Okay, teaching health literacy throughout the educational system. Obviously, patients need to understand basic things about healthcare. We can talk about screening, but many people don't even know what that word means. So that's an important thing to start early and while they're young. And changing some of the incentives for big pharma as well as big farms. I'm going to just give a short piece here on environmental things. It's a little bit aside, but it can show you the problem with healthcare, not healthcare, but with federal policy, while well-intended, if it goes astray. And I'll show you that towards the end. So this report, Advancing Primary Care, by the Council on Graduate Medical Education. Who is the Council of Graduate Medical Education? This was a group authorized by Congress in 1986 to provide an ongoing assessment of physician workforce trends, training issues, financing policies, and to recommend appropriate federal, private sector efforts to address identified needs. It's made up of thought leaders from academia, the private sector, as well as public health elected and appointed officials. So this is about a 50-page report. They had an executive summary. I'll just give you the 5 major recommendations that they made, okay, in terms of advancing primary care to solve these system issues that we've been talking about. I mean, we're talking about the same thing, okay? How do we make it better? How do we make the system better, okay? Well, number one, they feel like a dramatic shortage of primary care physicians for adult care and maldistribution among primary care physicians across the nation was a major issue. So this is projected to become worse with the attrition of an aging physician primary care workforce and decreased interest in primary care by medical students. So this number now is around 32% and declining. They recommended, let's set this as a target. 40% of physicians ought to be in the primary care space. This is age distribution of patient care, primary care physicians. Many of us are over 50 now, okay? And as this group moves over and retires, we're going to have even a greater shortage. And part of the reason is this curve that U.S. medical student seniors opting for family medicine from in the last 12 years. There was a little actually increase last year, and I think maybe some of the healthcare reform discussion maybe has started to pique students' interest back into primary care. So this actually went up a little bit last year, but it's been declining steadily. And I think actually we had a substantial number of our UTMB students this year match for family medicine, the most we've seen for quite a while. So hopefully that's going to turn around. Now here's the ugly topic. people say, well, doctors don't go into medicine for the money, right? We don't go into medicine for money, so. But everybody makes money. You have to have money to live and pay your kids college tuition and eat and so forth. But the fact is, there's a substantial differential between specialty care payments and primary care docs. So they recommended shooting for a target of that primary care physicians make a median of 70% of all other physicians. That doesn't sound too unrealistic. I'll show you the numbers in a minute. And how could that happen? Well, perhaps some of the ideas they had: preferential increases in fee for service payments for primary care, financial rewards for care coordination and performance measures, incentives for the patient-centered medical home. This is first contact access, patient-focused care over time, comprehensive care, coordinated care, along with family orientation and cultural competence, and bundling of payments for full-service accountable care organizations or community health care organizations. In the system we have right now, the hospital actually makes more money to amputate a diabetic foot than if I spend a half-hour counseling that person on diabetic management. I make a tiny little piece of the healthcare dollar, but there might, call it $100, but to amputate the foot, the hospitalization, everything might be $30,000. So the incentives are actually set to pay for technology as opposed to the kind of cognitive skills we do in primary care. Now here's a 2008 list of just what this looks like. First of all, most people would be very happy to make the kind of money any doctor makes. Even the non-physician providers here make almost $100,000 a year. But this is a number that you just average family practice, internal medicine, pediatric, $186,000 a year. Sounds like a lot of money. However, if you look at other specialists, average them, it's almost twice as much, $339,000. Now, why is that important? Well, for one thing, medical students are now graduating with record levels of debt. And they look down the road and say, geez, how can I afford to have a baby, have a car, have a house, and I've got, $200,000 debt to pay off. I better go into something that pays me better than and they're not going to start at $186,000, I'll assure you, if they're going to primary care. It's going to be closer to $150,000, $160,000. But in any case, to show how this tracks, this is an interesting correlation. This was a chart of, for some reason back in the early 90s, I think it had to do with some HMO reforms and how they paid for primary care. There was a spike in the payment, in the percentage of, or the income amount for primary care. Okay, that's this curve. Now look at here. This is medical students preferring primary care, going down, 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 down. Oh, this went up. I wonder if that had anything to do with it, okay? I mean, it's kind of an ugly curve, but that's a basic fact of human motivation. If they're making more money here and just track this just a little bit, say, well, maybe that's more interest. Now, as this has gone down, student interest has also decreased. So part of this is about changing the pre-med and med school environment, having accountable mission statements that really address social responsibility to improve health for all Americans. We're basically putting a lot of students through our programs, and we're doing a good job educating them, but are we being as accountable to the public as we should be? And this is going to require some reform of curriculum and admission process and class size, and to graduate more primary-oriented physicians. Graduate medical education. We should actually be measuring the specialty in practice rather than at the start of residency. When we say, okay, we have a good group of people going into primary care, about 80% of docs that go into internal medicine end up in a specialty as opposed to general internal medicine, which we definitely need more general internal medicine specialists. But the training models are pretty much oriented towards specialty training as opposed to outpatient ambulatory care. Other things could be done, salary adjustments, accelerated loan payments. Here's another slide just to show on the percent of number of PY1, postgraduate year 1 slots available based on income of the specialty. So in family medicine, there was decrease by 4%, peds 8%, okay, general internal medicine here it's even lower. I think it was minus 22%. I think that's a typo. But as you went up on the specialty income curve, more slots became available. So what we ended up doing is shoveling more students into these higher price specialties at the expense of the primary care end of it. So we've opened up more residency slots, but less in the primary care space. This is another slide that kind of shares the same story in a different way. There was a percentage of median compensation between these basically this 10 years, and percentage change went up in this zone 86, 76, 74%. They claimed inflation was 24% over that period of time. This is what family medicine, peds, OB-GYN did. We actually didn't keep up with inflation, actually. And we also found that there was a decrease in the number of students matching in all of our programs, 6, 10, 45, 80, 47% decrease over that period of time. But, you know, making a lot more income in this area here, and that does affect behavior, whether we like that or not. And then finally, you know, I was at a conference the other day, somebody said there's not really a lack of family medicine doctors in this country, it's a lack of family medicine doctors in areas that are underserved. Okay, in rural areas, in inner city areas, if we had even if we distributed the people that we have now to these areas and built teams, we'd be in a lot better shape. And there's a number of different programs, the National Health Service Corps, Title VII, AHRQ, some of the federally qualified health centers, AHEC, that are really trying to do this and innovate to distribute physicians better, but it's really hasn't really solved the problem entirely. There was an interesting series of articles, and I provided one of these for you in Academic Medicine in November, and they had something called a Question of the Year. And about 10 or 12 people responded, and it had to do, I never did figure out what the question was, but I got the answer. From the answer, you could tell they were talking about the issue of student debt and how to address workforce issues. And Sam Showmaker, who was our regional dean in Austin a couple years back, he's up at A&M now, wrote the Medical Marshall Plan. The Marshall Plan was how Europe was rebuilt after Second World War. The U.S. went in and provided a lot of supplies and equipment and so forth. And in this model, he said, number one, we have to restore public trust in medicine. If we're creating all of these doctors and they're making a lot more money than the average person, and yet they're not improving the health of the public, what's wrong? How can we change that? And so he suggested this would be by improving our service commitment to the underserved by the profession and by medical schools, and reinforcing our altruistic impulses that our students have when they come in, but we seem to kind of burn it out of them by the time they get out. But giving back in exchange for the privilege to serve in medicine, removing some of the financial pressures in medical school, and addressing major workforce issues, maldistribution and access of underinsured. And the article you've got in front of you has got a number of different techniques, but the idea is the first 2 years of medical school the tuition is covered, but there's some service to underserved communities that you do afterwards, after you finish your rotating internship, and then you decide whether to specialize or not. Many countries have this kind of program. We have a number of residents from Latin America. They all go out into communities after they graduate, and they learn a lot, and they provide a lot of service to people, whether that would be acceptable to U.S. grads or not. But a number of the different articles here, I just bolded the titles. You can look them up. They're actually only one-page essays where people just had a limited number of words they could put in. No debt, better education, better health care, what's not to like. Kansas medical student loan programs, successful tuition service exchange model. University of Chicago's got the REACH program. Service residencies, community partnerships, so a medical student makes an agreement with the community to come back and serve in that community in exchange for support, return of service programs and such. So there's a number of different thinkers about this, a number of different thoughts about this whole process of helping to put docs out where they're needed and expand the primary care workforce. Part of it is reducing debt load burden on students and putting them in places where they're needed in exchange for doing that. So those are some ideas, and I'm not going to go into them in further depth, but it's just part of the solution. I'm going to take a little aside now. In other news today, fattening food got cheaper while weight loss programs got more expensive. Okay? And I put this up because it's an example of a federal program that has gone awry and has in a way fueled many of our healthcare problems. Many years ago, the government, I think it was in the 30s, started to help support farms. At that time, farms in this country were primarily small family-owned affairs. And they felt like we needed, for all kinds of national security reasons and so forth, to really help these farms, because some of them were really having a struggle making it during the Depression and so forth. Now what has evolved now instead are large agribusinesses, and this is where your bacon comes from, okay? We're obviously supersizing our society. We are creating a situation where feedlots and so forth create what could be a healthy food form of protein, but by overfeeding and with corn and other grains and so forth, really taking grass-fed animals and putting them in stressful environments like this and making that food often unhealthy. Of course, we're using corn now for fuel, but this is part of the major way that we have supported this, but we pay corn farmers, hog farmers, cattle farmers, and so forth to be in practice. And the government has spent many, many billions of dollars in this space for the years. And this not only has effects on humans, it has effects on the environment. These red spaces here are oxygen-low dead zones as a result of effluent from the Mississippi River. All of that fertilizer, animal waste, antibiotics, other things that are applied in fields and to these animals gets eventually into the water supply, goes down the Mississippi River, and it's very rich in nutrients, so it feeds algae. Algae use up oxygen, and that depletes our fisheries and other species in the Gulf. So that's just kind of an example of one of the cultural trends that we have to address as we try to change our system. The egg of this doubled bacon, egg and cheese biscuit isn't going to hurt me, is it? Okay, he's got more problems than that egg. This is from Time magazine a couple of years ago. I thought this was very interesting, and this gets back to this issue of these farm subsidies. In the past decade, it's been over $50 billion, but the annual cost of obesity to U.S. healthcare is $147 billion per year. Okay, so we're giving farm subsidies at a fairly substantial rate, but our obesity epidemic is costing us much more. And one of the reasons this sustains itself is because of these farm subsidies that fattening and unhealthy food cost less. Okay, so $1 could get you 1,200 calories if you use it if you eat chips, or Coke, 875 calories. However, if you wanted to spend it on vegetables, okay, or fruit, you don't get nearly as many calories. Okay, so first of all, do you need that many calories from Coke or chips? But here, this is a problem. You have patients who have a limited income. It's a lot cheaper for them to buy this kind of food, and it's accessible, and it tastes good to them, and they get used to it, and it fuels diabetes, obesity, etc. Where this kind of food may not even be available in their neighborhoods, according to a study done by Lexi Nolan here recently. So I'm going to wrap up here with a few final recommendations, okay? Leland Kaiser is a health futurist, and he once said the difference between abundance and scarcity is creativity. So in an era of squeezing or vanishing margins in healthcare, it's essential that we leverage our resources and to wisely think creatively and know that the future is not likely to be like our past or even like our present. We need to create an environment of access to good health care, and health care that's affordable and does the most with the least. $1 spent in prevention can yield downstream $2 or more in savings in healthcare costs and disease treatment. So this environment turns out to be the primary care setting where we build a foundation to maximize public health. Certainly we've talked about improving, some recommendations could be improving loan repayment or forgiveness programs for medical schools, students, and other healthcare professionals entering primary care residencies and practice. Establishing a federal workforce policy that strengthens the goals of organized integrated care and rebalancing of this primary care workforce and specialty mix to a sustainable one. Reimbursement programs that and payment reform that encourages, not discourages, high-quality primary care, including that for the underinsured or uninsured. And then creating demonstration projects that actually validate some of the cost benefits of the patient-centered medical home, the primary care setting. Although there's lots of data available, I think healthcare policy people want to see more. If you're going to spend more in one area, such as primary care, does it really save us money? There's going to be a big bubble, I predict, of, shall we say, deferred maintenance when the gates open and all these people are insured. And it's going to cost a lot of money for people who have neglected to take care of their diabetes or hypertension. And initially, that's going to be very expensive. But downstream, it's going to be helpful. So here's some other things that I thought about. The whole idea of supporting wellness promotion and prevention, changing reimbursement for that. There was a humorous, and maybe not so humorous, example in the newspaper that Dr. Brody got involved with about death panels, the idea that Medicare should pay for us to talk to patients about end-of-life issues. Well, hello, I've been doing that for years. I didn't think I had any special billing code for it, you know, it's just part of what I do. But it got into some kind of healthcare policy, so you have to do this, and we're going to pay for it, and that became a death panel of some sort. And so you have to create time for meaningful encounters. So William Osler said it takes a minimum of 30 minutes to get the patient's full history. And I don't think it's changed. In fact, it's gotten probably longer, if anything. And so we don't really get a full history if we're crammed into these 15-minute office visits. I actually consider this social service requirement, linking to tuition payback for 1 to 2 years for all residency grads. It was one of my dreams to practice in a rural area, and I went to an area that hadn't been a doctor in 90 years. And I loved it. It was very, and the people were so grateful. And I worked there for about 8 years before I came down here. It was enormously rewarding. I didn't get any of my loans paid back, but I did it because it was my dream, and it was my mission, and my vision for what I wanted to do. So this can't be seen as punitive for our students. It's really part of their, in a sense, gratitude for giving back to society for the opportunity to be of service and to be trained in the wonderful profession of medicine and other healthcare professions. So how about making it less costly for medical students to choose primary care? We covered that. Stop subsidizing unhealthy foods for agribusinesses and at schools. That's starting to happen. Some schools are taking junk food out of the vending machines. The school lunch program is being looked at for the first time in 40 years for nutritional value. And how about encouraging a culture of increased physical activity for children and adults? All of this is going to affect what we do for our kids. So we got the supersized meals over here, we got the supersized clothes, and then we got the supersized hospital bed with diabetes, heart disease, et cetera, et cetera. These kids, I have kids in our practice in family medicine that have a BMI of 50. They're 9 and 10 years old. It's scary. These kids are going to be needing cardiac stenting by the time they're 25 years old. They're going to be on insulin by the time they're 20. Instead of superfood diet, we have that as our current situation, and we need to encourage healthier foods and make them more affordable. So this is one of my favorite people of all times, Thomas Edison. He said many years ago, he's an inventor, the doctor of the future will give no medicine but will interest her or his patients in the care of the human frame in a proper diet and the cause and prevention of disease. I altered it a little bit. I put her in there because he just used his. And then I also changed it here. I don't think it's bad to give medicine. Medicine is good. So we'll give some medicine, and we are going to interest them in these preventive measures and the cause and prevention of disease. And this is going to make for healthier people and a healthier planet. And if you wonder if that's the end of the story, it isn't, but here's the sharks at the movies. I just love happy endings as they watch the Titanic go down. So, all right, that ends my presentation. I'd be happy to take any questions or reflections you might have.
ahead. Questions?
The New England Journal of Medicine did a study that was rather disturbing, that if Obamacare goes into effect, that 50% of the primary care doctors in the United States will quit as soon as they can transfer.
Well, Dr. Vogelpohl, I didn't see that study, but that is a disturbing concept. I do know when I was in private practice in Colorado and also in Chicago before that, that the reimbursement for Medicare actually didn't cover the overhead costs of seeing the patient. Overhead costs in a well-run medical practice is about 50%. When you bill Medicare $1, they pay you about 42 cents. Okay, and so you actually are providing charity care in a sense to Medicare patients. And you don't make it up on volume. You see more Medicare patients, you just lose more money. But of course we saw them because they're valued members of our community. But this is one of the challenges in geriatrics now too. You don't have a lot of procedures and other things like that. And so if the model for repayment is based on Medicare funds or Medicare prices or Medicaid, which is even worse, and the paperwork that's involved in generating bills with Medicare, I can certainly imagine that could be a discouraging factor for primary care physicians. And some physicians now are not taking any new Medicare patients. They just say, can't afford to do it. And that is a shame. It's people who have paid into Medicare for many years and they're old and they need care. And our system, again, downstream, has created this bolus of folks with poor coverage for their care that through no fault of their own. Thanks for that comment, Dr. Vogelpohl. Anybody else? Emilio?
I think the issue of lack of federal code reform, even to the practice of defensive medicine, every time I write a note in the chart or method, I'm thinking that someday perhaps that lawyer is going to be reading it. And I end up probably ordering more tests that are necessary. And I'm thinking that if we just do away with the practice of defensive medicine, it would save the system billions of dollars. That's one area that I'd like for you to comment on.
Right, and I agree with you there. I think that there's abundant evidence that changing the way we deal with patient accidents, for example, going and fessing up to the patient and apologizing reduces the claims. But tort reform has certainly been cast about a lot as part of the way we can save money in this system. The challenge is that the trial lawyers make a lot of contributions to political campaigns, and they make a lot of money. You get a $5 million settlement, and you get $2 million out of that if you're the lawyer. You're making a pretty good living. When I first moved to Texas, there was a huge group of spurious suits against OBs down in the valley. And they found that just filing a suit, they would get $20,000 bucks, or $17,000 Oh, my baby's got a little finger thing here. It must be the OB's fault. And so it got to a point, and it got to this point in Florida too, where docs were just not going to deliver babies anymore. It just wasn't worth the hassle. And so it wasn't until Texas reformed their tort law to get rid of those kind of spurious claims that people actually then came back and started delivering babies. But in the meantime, the cost of care went way up. And as you said, just the cost of time to document, the conversation with the patient and all of this and do some extra tests just in case that little headache really was that 1 in 10,000 patients with a brain tumor. Let's get the MRI. And nobody will criticize me if I do that. But in fact, accountable care organizations are going to be starting looking at outcomes because we're going to have to look at the whole spectrum of care from start to finish and say, does that really help with that patient's care? Was that evidence-based or was it fear-based, based on, the malpractice concern?
Right now, given the lack of incentives and the need for documentation, I think we end up treating the computer and the chart much more so than we documentation.
Yeah.
And 15 minutes just doesn't do justice to encounter.
I agree.
The other thought that came to mind when we were trying to compare cost in different European countries in the U.S. is that I'm not 100% sure, but I suspect that this country is the only one where medical care is based on profit-based insurance companies. I don't think the system is in place in Europe. Are you aware of any similar system in Europe whereby people make money off of patient services?
Well, you don't have to even look at Europe. If you look at how medical care costs have been reimbursed in the last 30 to 40 years, starting with the passage of the Medicare Act in the 1960s, that the gap, the escalation in costs accelerated dramatically, not just because of medical technology, but because patients didn't have any idea what their medical care cost, nor did they care. And the physicians and insurance companies were like kind of complicit with this. And then order some extra tests, I'll make a little extra money, the patient will be happy, they feel like they're being taken care of. And now the ship has hit the sand, so to speak, with with patients facing these escalating premiums. I mean, it's no longer can we do business as usual. So I do think that's been a driver. When I was in high school, I was on the debate team, and this was, if you're on the debate team, you have to prepare to argue both sides of an argument. Okay, and it's very interesting. So at that time, what they gave us was a book about this thick about the British socialized medical system, what they called the UK system. And it's very interesting looking back at that, because there were pros and there were cons about that, and you had to be prepared to cite chapter and verse of why this was good or why this was bad and sit on both sides of the table. So I've tried to give you somewhat of a neutral point of view. I don't have all the answers certainly for healthcare reform, but I do think we do need to reform healthcare, not just the payment system about healthcare, to make a substantial difference in the public health and in the quality of the care that we can provide as professionals, because I think the current system is grinding people down into a situation, like you say, that, or like Dr. Vogel says, I don't want to do this. I'm going to go join the senior golf circuit or something. Okay, so, all right, thanks. I got to get back to clinic, but I understand you've got some other activities scheduled, Tony. So, okay.
Okay, we have just a little bit, just a real quick video that I'm going to show. Some of this is more for your entertainment, as well as just put a little lighter side on this. Some things that Dr. Serafina is talking about can't be the most uplifting in the world, but it was excellent information, and I appreciate all the comments. If there are any calls as a webinar, I have put the phone number there that others who are chiming in from their PCs to call 409-797-1298, and then for the passcodes 2222, and then the pound sign. I hear that if they call, it's going to go to the control room, and then there will be a voice of the question. But so far, we won't be doing that. But I do want to put this video on, and this was sent to me from HRSA. I don't know if anybody's seen the healthcare reform explanation. It's about 9 minutes. I think it's pretty classic. And I think you might enjoy it. And we can have some discussion or some questions if you'd like.
Let's face it, folks, the new healthcare reform law is complex. It runs about 1,000 pages, even in tiny print, so it's no surprise that very few Americans have actually read it. But it's about to affect all of us, and many have been wondering what it will mean for our health, our wallets, and our country. Let's say we take all 310 million Americans and squish us down to just 25 people. Yep, each of these folks would represent about 12 million of us, and this is pretty much what we'd look like. Polls show about 3 out of 10 of us say healthcare reform will make us better off. A similar number say worse off. And a similar number again say it won't make much difference at all. Some of us don't know what to think. I guess you could say we're kind of split on this one. But no matter where you stand on the issue, it's likely you're thinking, hello, I got some basic questions still unanswered here. And you deserve real answers, not the partisan rhetoric and spin we've been flooded with. So let's break down what the reform law does and doesn't do and what it will cost. If you want to read the whole law, go ahead, but watching this video is the next best thing. Ready to jump in? Let's begin with the problems in our current healthcare system. Problem number one is what problem number one usually is: money. Most people agree that health insurance policies are too expensive. For a family, the average premium is almost $14,000 a year and growing. Premiums have doubled over the last 9 years, ballooning way faster than inflation. Plus, our population is aging, meaning more people with more health problems. So health care costs are the fastest growing part of the federal budget. The second problem is that the system is full of holes, like the fact that people buying insurance on their own can be turned down for having a pre-existing health condition. Small businesses may be charged extra if some of the workers are sick, making insurance unaffordable. And some insurance policies have a lifetime limit on benefits. After that, you're out of luck. That means some of the people least likely to have coverage are the ones who need it most. Nice, huh? High costs and holes in the system mean more than 1 in 7 of us have no health insurance to protect us at all. Many more struggle to pay their bills and can only afford bare minimum policies that may not cover much. High cost to households, strain on the federal budget, and people with no protection. It's easy to see why many people were looking for something different. So here's what the health reform law plans to do in its first phase between now and 2014. To start dealing with cost, insurers would be limited in how they spend our premium dollars. If they use too much for administrative cost or profits, they'll be forced to give some of it back through rebates. This won't stop premium increases, but it may help some. Some services will become free in all new private insurance policies and in Medicare, preventive care like screenings and vaccinations. People on Medicare, because they're over 65 or disabled, will get more help with their drug cost. Young people can save money and stay insured by remaining on their parents' policies up to age 26. And some small businesses will get tax breaks to help them pay for health insurance for their workers. And the holes, well, some will be closed starting now, too. Lifetime limits on health coverage will be gone, whether you buy your insurance on your own or get it from your employer. And it will be illegal to turn kids down for having a pre-existing health condition like asthma or diabetes. Of course, some adults who buy insurance on their own will still be getting rejected between now and 2014. Those who do can enter something called a high-risk pool run by the government. No, it's more like a policy that covers the sickest uninsured people, meaning it's riskier for insurance companies. That's why the government will chip in some money to bring down the cost. Some say these high-risk pools will help a lot of people. Others say the pools will still be too expensive and may not have enough government money to stay in business until they're replaced by something better in Phase 2. On New Year's Day 2014, some big changes kick in. First, let's look at how the law makes health care more affordable. Medicaid will be expanded to cover all low-income individuals and families in every state. And depending on what you make, if you lose your job or your employer doesn't provide decent coverage, you may get a health insurance tax credit. And while most of us will continue to get health insurance at work, just like now, if you don't have that option, you'll be able to buy coverage in what's called an exchange. You'll be hearing a lot about them, so let's stop and look at how they work. An exchange is like a virtual insurance mega mall. Based on where you live, you'll get an easy-to-understand menu of options to compare plans in plain English, and the exchange makes sure insurance companies compete fairly under strict rules. The idea is that by giving consumers good information, a fair playing field, and access to lots of choices, competition among insurers will keep rates competitive.
Okay. That's right.
Now, on to plugging the holes. In 2014, insurers will no longer be able to turn people down or charge them more if they're sick. You might say, hold on a minute, if I can't be turned down or charged more, why not just wait until I get sick or injured to buy insurance at all? Not so fast, buddy. See, with few exceptions, people will be required to have insurance or pay a special tax. Same with larger businesses, who will pay fines if they don't insure their workers. Of course, nobody likes being told they have to buy anything, but without this rule, experts say you can't require that everyone be eligible for coverage. Imagine telling home insurers they have to cover people whose houses are already on fire. So the government will provide credits, expanded programs, and new rules. They say that by 2019, 32 million of us who don't have health insurance will have it. Some of those who will still be uninsured, undocumented immigrants who aren't eligible for coverage under the law. No surprise, all this is going to cost money, $938 billion over the next 10 years, according to the Congressional Budget Office, the impartial referee when Congress debates these kinds of things. It's a lot of money, sure, but if you look at it another way, it's 2% of our federal budget and 3% of what we'll be spending on health care overall. Now, the President and Congress insisted these new costs will be paid for so they don't push the budget deficit up any further. That means money will come out of someone's pocket.
What?
That's where the tough politics come in. A lot of savings will come from health care providers and insurers in the Medicare program. The fees the government pays to hospitals under Medicare won't be allowed to rise as fast as they have been. And insurance companies that provide services to people on Medicare will be paid less. Medicare will also create a bunch of experiments around the country to test different ways of paying doctors, hospitals, and other providers to make the healthcare system more efficient and improve the quality of care. With luck, some of these experiments will work and then be adopted by the private sector and help lower costs for employers and families, too. Plus, a new federal advisory board will make recommendations about other ways to deal with increases in healthcare costs. Some taxes will go up, too. People with high earnings will pay higher Medicare taxes. There'll be new taxes on insurers and businesses who offer high-end benefit plans and on companies that make medical devices and drugs. And, anyone who visits a tanning salon now has to pay a new tax, too. With these new cost-cutting measures and new taxes, the Congressional Budget Office says the whole package will actually reduce the federal deficit over the next 10 years. Of course, the total federal deficit is expected to run into the trillions, so the health reform law isn't going to solve that problem. Well, that's the reform law. Do you love it? Hate it? Still don't know? Either way, there's still a lot of work ahead. You'll be hearing lots of different things about this law. Some people support reform and, if anything, want to expand it and increase government oversight of insurers in the healthcare industry. Others oppose it and think it creates too big a role for the government. Some states have even gone to court claiming the requirement that everyone buy insurance is unconstitutional. Politicians and pundits will be talking to you as if you've got no idea what's in that 1,000-page law. But by watching this, you're on your way to getting informed. And you can make sure your friends and family are, too, just by passing this little video around.
Get over to you, so I'll be sure to send that. It is pretty classic. I love it. And we have, other hand, Dr. Serapina had changed his slides, so some of the things that he talked about, like I think there were some references in there that they were not in the handout that's in the back. If you want that, again, on your sign-in sheet next to your name, let me know and I can send you the updated slides for some of those references. And they were valuable resources, I thought. I think this was a really good session. We have in 2 months, looking a little more in depth at standardized care. We have a really great set of, we're going to have some medical students talking about some of their feelings and some of the ethical situations that they're dealing with through letters that they've written through some of the courses, through working with Dr. Karen Sauter, the medical director for the standardized patient, and many of you know her. So that's kind of on the docket for April, and I think we're on our way to continuing this discussion. If you have paperwork for your CE credits, you can give them to Kelly in the back on your way out. There are the general evaluation forms for this session that I'd appreciate it if you fill out. Just in case. If you are new to this session, Kelly, we do have participant profile forms, right? Okay, if you haven't participated in last month's and you are new for today, there's a participant profile form that's really important because that's how we get our information to HRSA in terms of our progress reports, in terms of who we reach. I thank you for being here today, and I hope to see you again in a couple of months. Feel free to contact me if you have any information or questions. Thank you.